everybody. Thanks for trusting your time with us. Depending on where you are, I heard maybe getting into home-based primary care, somebody like me who's been doing it, essentially for his lifetime. This could be a review or this could be an introduction. Just what do we do in home-based primary care? We do primary care just like another doctor down the street here. We give checkups, we give vaccinations, we draw blood, just like you're going to a regular PCP. As you can imagine, the majority of our patients are older. The average age for our practice is a little north of 82 years old. And many of them that we take care of have chronic diseases. And you can imagine some of the challenges that we face or the diseases that you may need to be comfortable managing for those who are considering getting into home-based primary care. That being heart failure, COPD, CKD, atrial fibrillation, dementia-related behavioral disturbances, diabetes. Those are some of the common conditions that we manage in home-based primary care. We're available 24/7. We don't actually go out, my practice, we don't go out in the middle of the night. We do make ourselves available by phone or urgent visits the following day or maybe by televisit now that COVID has given us another avenue, if you will, to engage with our patients. We do a lot of post-acute care or transitional care management. As you can imagine, many of our patients, they do end up in the hospital for different reasons. And when they are out of the hospital, it is our responsibility to go back in and see them, make sure they have all of their meds, they have the services that they need to support them, go with advanced care planning, any changes in their thoughts regarding resuscitation orders, and so forth. That's also a large part of what we do in home-based primary care. Annual wellness visits, I talked about immunizations. And as you can imagine, many of our patients are chair-bound or bed confined, and they do develop pressure sores. And we do wound management, other procedures. Some of our patients may need injection in their knees because they're in pain. I'm seeing a patient next Tuesday. We're going to change a feeding tube. The following Tuesday, we're changing a tracheostomy tube. So these patients, without us, access for them is very difficult. Of course, we can't do this in isolation. We need a team to help us support our patients. And we do order blood tests, x-rays, imaging, and so on to help us manage our complex patients. So that's a very quick summary of what we do in home-based primary care. Now, we're here also to talk about home-based palliative care. Home-based palliative care has some similarities with home-based primary care, but the focus may be a little bit different. Yes, we see patients at home. Our Northwestern program also, not only do they see patients at home, but they also see patients in their nursing facility. And the focus is on symptom management, as many palliative care services are. They're asked to see patients with intractable pain, shortness of breath, irritability, delirium, to help manage your symptoms, especially in those patients who's got chronic illnesses. There could be a lot of complex family dynamics that's involved in caring for these patients as they're struggling with decision-making, the power of attorney, advanced care planning discussions, and so on. And the palliative services, they're a huge advocate. They're a huge benefit to help us navigate some of the challenges when we have complex patients at home and that we're trying to get a clear direction regarding and whether you're managing their symptoms or their future care plan. And as all of us know, that there are now, or there is an emphasis now on not only the medical side, but also on the social determinant side of care, which impacts the lives of our patient, the well-being of our patient. So the palliative care team can be a huge asset again in helping us navigate through some of the non-medical needs of our patient, as well as supporting them through interdisciplinary care to address spiritual concerns or psychological issues. There's a patient of mine I recall. She really was hesitant on taking pain medications because she felt that through pain she can somehow be made pure or justified before God. So definitely somebody who's got more insights into spiritual side of and the psychosocial side of care can come alongside of this patient to help her work through that concept of pain as a way of purification or justification. We see that the home-based primary care has its role in terms of what we do. We talked briefly now about the home-based palliative care team, and there is an intersection, right, between the two service lines, if you will. There's the patient and family care support. I talked briefly about the spiritual needs and the coordination of care, the need of a team to help support our complex and sick patients. Symptom management, whether you're doing primary care or palliative care. We talk a lot about how your bowels are doing and how's your breathing and so on. So we do manage the symptoms. So whether you're on either side of the circle, and we assess the functional abilities or disabilities of our patient and give them what support is possible. I already said enough about having teams to do what we need to do to help support our patients. And hospice care, somebody's here from hospice. A lot of our patients, whether you're from the home-based primary side or the palliative care side, that is an opportunity for us to talk to our patients, introduce them to them about the idea of hospice. There's some demystification that's necessary when you bring up what I call the H word, right? Some people have very strong feelings when you talk about hospice from perhaps what they've read on the internet or maybe some personal experiences they've had with maybe another family member. Goals of care, obviously, an advanced care planning discussion, whether you're on either side of the circle, the kind of patients that we deal with. It is really important to have those discussions done. And it's not one of those you just do it once and you put it aside. As I stated earlier, during our transitional care visits, one of the things that we do is to revisit the advanced care planning discussion and go over the resuscitation order because many of these patients struggle during their hospitalizations, and we ask them, what was tough about this, and have you changed your mind about if something like this is to happen in the future? Do you want to go through this again? If not, how can we help answer any questions or concerns you may have? One last comment about the hospice, the intimacy that we have with hospice, whether you're on the home-based primary side or the palliative care side. Roughly 25% of our patients pass away every year, and that's been steady for a long time that we've been doing care at home, and I think Rebecca's numbers are very similar to the numbers that we have. So that's just a quick introduction into the two circles, the differences, and perhaps some of the common grounds that home-based primary and palliative care share. Now, the reason we are bringing this to to your attention and talking about it and putting out conferences is that we want to better support our complex patients at home. What can we do to serve this very needy group, and I say needy not in a negative sense, but as a reflection of just their illness. How can we serve them better? I actually had a call this week with Northwestern on exactly this. How can we take care of these patients better, treat them at home, minimize the trips to the emergency room and hospitalizations where they don't want to go. If that's the case, then how can we take care of them? So with that, I'm going to turn it over to Rebecca.
Great. Thanks, Paul. Well, first of all, I want to just thank you to HCCI for asking me to come and present to you, and more importantly, to have a dialogue with you. I actually have the pleasure of sitting on the board for HCCI for the last couple of years and have learned a tremendous amount from Melissa and Paul and Julie and others at HCCI. And so this is my opportunity to give back to the organization and to all of you. The other thing I'll say is that I will be talking more specifically a little bit later about our practice. So I'm going to wait to give you kind of share the credibility that I have about the content I'm going to share until we get to that sort of case study. So you'll kind of understand where all of this insight is coming from. I just didn't pull it out of the clouds, but we actually are doing a lot of this work and serving a lot of patients in a similar way to what Paul has been talking about. But first, again, the question might be, why are we talking with you about bringing together hospice, home-based primary care, palliative care? What is the benefit of that? And who is it benefiting? So first and foremost, we want to serve these, very complex, often homebound patients with the very best care model that we can. And when we bring together home-based primary care and home-based palliative care, we're able to serve a broader population and more fully meet the needs of patients and their families. I'm a real champion of team-based care, and I know Paul is as well, because he mentioned it. Palliative care, and in particular, those of you that are, have a lot of experience with hospice, how important that interdisciplinary team is to providing holistic care and meeting all the various needs of patients, caregivers, and their families. And that's what we bring together when we think about expanding, our hospices or our primary care practices to really think about how are we serving the full spectrum of serious illness and advanced illness for patients and families. And the principles of palliative care also really focus on not just, what is the medical problem and what is the medical treatment plan, but actually what matters most to you, the patient and the family and the caregiver at this particular time. How can we align the treatment plan to what actually matters to you? So it's a very collaborative care model. The other thing is that from a business perspective, there are more and more reimbursement opportunities available to home-based medicine practices who are doing this full spectrum of serious illness care. And in addition to value-based contracts, which we're pretty involved with, and I'll talk a little bit more about when I talk about our practice and the case study, but there are actual fee-for-service billing codes that can be optimized and used to help to cover the cost of team-based care. So not just the typical physician or, PCP or palliative medicine evaluation and management codes that people are pretty aware of, but there are care management complex care management codes that can be billed by MAs, by nurses, by social workers. And that helps to actually diversify the kinds of services and cover the costs of a team-based model. The other real benefit among so many others is we know, because we have tons and tons of evidence and research, that at the end of life, when someone is suffering from a terminal illness, hospice care is highly satisfying to the patients and families. It lowers the cost of care for the healthcare system. It enhances the quality of life for the patient. And that palliative care, which is, can be confused. People still get very confused. What's the difference between palliative care and hospice? Palliative care is offered to patients. It can be offered at any sort of time in their life. They don't have to be near the end of their life. They don't have to have a terminal illness. But often it is offered to a patient when they have a serious diagnosis, a life-limiting diagnosis that may end up becoming terminal in the future. And we know, because we've studied it, that palliative care tends, when patients and families receive palliative care, they also tend to benefit from earlier referrals to hospice. One of the biggest problems with hospice care in the country is that over 50% of the referrals to hospice happen in the last 2 weeks of life. And the benefit of hospice is actually greater beyond 2 weeks. So you get a bigger benefit if you're actually receiving hospice services for longer than 2 weeks. So palliative care often is a really nice way to introduce families, really get to understand what matters most to them, to have those goals of care conversations before the patient is diagnosed with a terminal illness. And it does result in earlier referrals to hospice. So in talking about sort of this combination of home-based primary care and home-based palliative care, we're going to share kind of two options that seem to be becoming the most prevalent in the industry, in our home-based medicine industry. And actually, both Paul and I have experience with both of these models. So we can give you some specifics from our own experience. The first model is what we call a co-management or consultation model. And this is where you actually have a separate set of providers or care team members under the same umbrella organization, or maybe you're collaborating. So maybe you're a hospice or a home-based primary care provider organization, and there's some kind of subcontract that you have with another organization providing more of the palliative care services. But it's a separate team, and you're trying to bring the two services together and allow patients to benefit from both palliative care and home-based primary care at the same time. But again, they're separate teams, separate providers. The other model is what we call a fully integrated model. And so this would be where your home-based primary care team is also trained in palliative care and is able to, as a patient's illness trajectory changes and prognosis changes, you're able to kind of layer on top of the primary care services the complex illness management and serious illness management palliative care model. I don't know, Paul, if you want to talk before I move on, if you want to add anything to this, because you certainly have as much experience as I do with these two models.
Yeah, so I think we're going to talk about this later on in our presentation as well. So I'll just speak from my personal experience. From the practice I've been involved with the longest is the fully integrated model. As Melissa said, I'm board certified in both hospice and palliative medicine, as well as internal medicine. So I feel completely comfortable managing the patient's chronic illness. And if they transition into palliative medicine or to hospice approach, if you will, I am totally fine with writing controlled substances, whether it's fentanyl or morphine or even methadone for our patients. So that is the fully integrated model, and we can talk about the advantages and disadvantages of that maybe later on. So that's the practice that I've been with the longest. Now, Mickey is here from our Northwestern South region with their palliative care program. And the practice down there is more of a co-management, where there are separate providers involved in, with one provider doing mainly palliative medicine, the other one doing primary care. So again, I think later on in our talk, we can dissect the different models a little bit more, but that's just at least for this at this point, it's just a brief introduction.
So a little bit more about the co-management or consultation model. Typically, this is run as an independent collaborative service line, again with separate providers. Often it's thought of as a wraparound support. So from the perspective of sort of a consultation, if you think about a consultant model, you may have a primary care provider that's providing primary care either in a brick and mortar setting or in a home-based practice, like house call providers or Paul's practice. And in this model, those primary care providers maybe don't have a lot of experience with managing serious illness, and maybe they don't have a lot of experience with the collaborative goal setting and goals of care conversations and developing, pulse, et cetera. And maybe they don't have a lot of experience managing complex symptoms when patients are dealing with advanced illness like, stage 3 and stage 4 cancer or severe heart failure. And so they actually seek that consultative support from a separate palliative care team. This model obviously requires really tight optimal communication between the home-based primary care provider and team and the home-based palliative care team. And that may be thought of as one of the disadvantages of this option, because we know in healthcare, whenever you are using separate service lines, there's always a chance that the communication falls through the cracks. So that's a really important distinction, I think, between these two models. And again, this is appropriate for patients of all different levels of care need. Patients, certainly don't need to have a terminal illness to benefit it. Typically, the target population is going to be a patient with multiple chronic conditions that are on the more serious or advanced side. In terms of the staffing model for a co-management or consultation palliative care team, there's really no right answer. I talk to a lot of people across the country who are building or have built these types of models. And again, I'll share from our perspective what we have done. Often there is a physician or even more nowadays, a nurse practitioner who's trained in palliative medicine or has a certification. There's often a nurse or a social worker. Again, often they have a specific certification in palliative care. Chaplains or spiritual counselors are often really beneficial in palliative care models. We actually have pioneered, I wouldn't say we've pioneered, but we were one of the first community-based palliative care programs in our region to add a particular role that we call actually a social determinants of health specialist. We used to call them outreach workers. There's a lot of new literature coming out about the benefit of individuals with lived experience or community health workers on these palliative care teams. We have the benefit of having a palliative care trained pharmacist. So there's an actual pharmacy certification and training, specifically in palliative care pharmacy. And we just totally lucked out. And so we have a palliative care pharmacist on our team. And, I can't pretend to be an expert in all the other sort of innovations that people are doing across the country. But I think the point here is that it's a team, and that these complex patients need a lot of different types of support as they're navigating their serious illness. So then let's talk a little bit more about the fully integrated model. So this is the other sort of model that we see in the industry. And so this is where you have a home-based medical practice providing both primary care and palliative care, which requires that the providers and the care teams are trained in all disciplines of integrated care. So that's, I wouldn't say it's a negative but it is a cost in terms of really either you're looking for a specific skill set when you're hiring care teams and providers, or you're training them in whatever discipline they're not as familiar with. But the huge benefit to this is that a fully integrated model ensures that patients can actually receive both primary care and palliative care as their illness trajectory and health needs change and shift over time. And it also provides really great cross coverage. So you just have a deeper bench because you have a team that can flex and shift because they're more broadly trained to provide the full complement of complex illness management services. Also, it minimizes the miscommunications and the dropped communication that can occur when you have two separate teams providing these services. And I think ultimately, just because of that decrease in communication challenges, it probably results in higher patient and caregiver satisfaction, unless the consultative or co-management model has done a really good job of closing those gaps and making sure that they're working in a really collaborative manner.
You have to look at your community, what the needs are, get a sense of are the providers comfortable managing patients with advanced illnesses, or do they have a tendency to maybe do a handoff for somebody else to manage these very, very sick patients? There's not one right model for this. As Rebecca said, you have to look at your own skill sets, your teams, your budget, let's not forget that, right? And also the needs of the community and how things in your communities are usually handled, whether it's a co-management model or more of an integrated approach.
So let's talk a little bit about staffing models for the fully integrated option. And I'll speak specifically about house call providers here, and then Paul can share a little bit about his staffing model. So we actually operate both a integrated home-based primary and palliative practice. We've been, and this is our house call providers. We call it our primary care program, home-based primary care program, but it absolutely is the fully integrated model. So we're actually providing palliative care as well in this model. And we've been doing it for almost 30 years, since 1995. We currently serve 1,550 patients across a pretty broad metro area around Portland, Oregon. So we cover 3 counties and about 3,000 square miles with our team. So we're on the larger side, practices across the country. And we have, in that program, we have, to care for those 1,550 patients, we have a chief medical officer who's board certified in internal medicine and hospice and palliative medicine. She's also done she's been a hospice medical director for many years. So that right there kind of gives you the sense that, that person who's overseeing all the clinical care is really highly trained for the full complement of serious illness. We also have an associate medical director who actually has been with the practice for almost 20 years as a geriatric DNP, nurse practitioner, and has been providing home-based medicine for over 20 years. And then we have, and this changes and shifts, but we have somewhere between 13 and 15 primary care providers, all of whom have either have experience in palliative care. Some of them have done certifications. Some of them have worked in hospice and palliative medicine in the past. The vast majority of those are nurse practitioners, but we also have 3 other physicians and a physician assistant who are providing primary palliative care. And then supporting those providers, we have clinical field staff that are also trained in palliative care and complex illness management. So I spoke about the clinical pharmacists that we have. We also have 4 social workers, 4 nurses, a behavioral health specialist that does specific behavioral health counseling in the home with patients who need that. And then we have a chaplain. So those are all field-based. They're making home visits. They're not in the office. They're making visits in between the times. And sometimes they make visits, they make visits along with a primary care provider. And then in the office, to support that large clinical team, we have care coordinators who are mostly MAs. We have 2 intake specialists who are helping people get onto the service. We have 2 schedulers. We use a GIS mapping software to schedule our providers and our care teams so that it's most efficient. We have 2 medical assistants who are in the office, and then we have an office-based nurse who does a lot of triage. So it's a really robust team. We haven't had this team for the whole 28 years. I would say that many of the office-based staff that are here on the slide, we've actually just added in the last couple of years as our panel sizes for our providers are getting larger. We're in a somewhat of a unique situation where almost since the very beginning of house call providers' existence, we've had more demand than capacity. So we typically will run a wait list of about 120 to 200 patients at any given time. And that may sound like a lot, but with a 20 to 25% mortality rate, we're able to get most of our patients, depending on the territory, onto service within a month or so. I would certainly love to see that be shortened, but it's just incredible the amount of demand that we have in the region. And then I'm just going to hand it off to Paul to talk a little bit about his model.
I was thinking we have a lot in common, Rebecca. Your practice started in the 1995. Ours started in 1997. The abbreviation for your practice is HCP. And so and we are ACP too. How about that? And your patient panel is fairly large, and combining my panel with the Palliative panel, both in primary care and palliative care, we are close to 1,800 patients. So we are we're similar in many ways. But then the similarity ends. Look at the 2 slides. Look at the slide and look at the staffing difference. I wish I had a pharmacist. That'll be nice. Especially, we published a study with the help of a pharmacist who I got connected through my work with hospice. The average number of medications my patients take, 17. I would love a pharmacist. Okay? So either you have to be really good in your pharmacology, or you got software to help you, or you got a pharmacist. Okay? I would love to have a pharmacist. I would love to have a social worker. Actually, think about this. We've been around since 1997. We just got approval for a social worker as of this morning. Okay? And hopefully we'll have more time to discuss why Rebecca's ACP has this kind of staffing, and Paul's ACP is pretty slim. Paul's not, I don't think I'm cheap or extra frugal, but the payment mechanism is very different between our two sides. It's as wide as here to Oregon, all right? But again, hopefully we'll get into a little bit about payment, whether you're fee-for-service, value-based, different APM models. Come back to the session in December. Come back to the session in April, is it, Melissa? March. Maybe we can just spring forward to spring and kind of skip the winter thing here in Chicago. But anyways, we're going to, whether you're operating under fee-for-service or different APM models, efficiency is going to be important. You know, we're a mobile practice. We have to take care of our patients. You heard Rebecca, they have a waiting list of 200. Okay, we need to get to our patients and take care of them. So how do you make things efficient? And then the following session is going to be contracting with payers. We know that we're moving away from fee-for-service. It's going to be tied to quality and value in the future. That is the future, and I think that's one of the reasons that finally Northwestern is saying, "Hey, I think you guys need a social worker." And yeah, we need you at the table to discuss about readmissions and so on. So our team is very lean. I'm part-time. It's actually 1.2, combining the two docs together, 4 full-time MPs, and you see the rest. We don't have some of the additional support team that Rebecca's ACP has. As you are thinking about getting into primary care or maybe expanding from palliative, going into primary care, think about your revenue source, think about cost, think about what support staff you may need. And also, can you share some of the support? For example, can you share a social worker to help you with some of the social worker needs by getting home health involved with a patient who's got chronic XYZ diseases. So that's how we've kind of worked around because the budget simply under fee-for-service will not support a robust team like Rebecca's. Any questions?
I know. Do they have to be homebound to qualify for the primary care?
Yep. So homebound status, that only applies to home health, nursing, therapy, and so on. We are not bound by the homebound wording per Medicare. We see patients, I have a caveat to add after that. We see patients because of their intensity and need, not necessarily their homebound status. Now, the caveat to all of this is that when you are that sick with that many conditions, you're likely what? Homebound, right? So there is the legal side that no, we take care of patients, they're not homebound, but on a practical side, most of them are homebound. Rebecca, any comments you would like to add?
Yeah, I would say that everything you're saying, I agree with. Most of our contracts are now with Medicare Advantage plans and Medicaid managed plans or dually eligible managed plans. And they definitely are referring non-homebound patients who really just need a lot more support than they're getting in a 20 to 25 minute primary care or even a palliative care visit in a clinic. And then, often they just have, so they need more support, they need more frequent visits, they need longer visits, and they may not really be homebound, but like Paul is saying, they have so many barriers, whether it's social determinants of health barriers, transportation barriers, cognitive impairment barriers, physical disability barriers, that it's just a huge burden, for them to go into a clinic setting. So everything you said, I'm just amplifying what you said. one of the absolutely most important tasks for someone who is overseeing or running a practice like this is finding the right people, finding the right providers and clinical team members. And it's both critically important and also is one of the reasons why I absolutely love my job, is that the people who are drawn to this kind of care are phenomenal human beings. And many of you in the audience, and certainly Paul is among that group that I'm describing. They're just really amazing people, totally mission driven, oriented toward patient care, wanting to really be a part of someone's healthcare journey. And but it's not always easy, and finding the right workforce is the biggest challenge that we face in our region. There's more demand than we can hire providers and care teams to fill. Because it's a little bit of a narrowing of the funnel, right? In terms of looking for, the right skill set. And when you're providing care, as many of you know, I know I'm talking to a lot of really experienced people, but as you know, when you're providing care in a home setting, it's not like being in a clinic or a hospital where you can curbside somebody and pick someone's brain. I mean, you're operating really independently, relatively independently, and you have a lot of autonomy, and that's both something that really draws people, but it also can be challenging, particularly we're finding, which is exciting, we're finding that more and more newer grads coming out of nurse practitioner school or family or internal medicine residency programs. And we're needing to hire those individuals because they have the passion and the commitment, but there's a lot of training and a lot of support required. And that's why HCCI is so valuable, because they have so many amazing training programs available for people who are wanting to get into home-based medicine. So anyway, the sort of key competencies for providers and clinical care teams that are doing this work, most of this we've already touched on, the ability to manage patients who are on 17 different kinds of medicines, and often have pretty complex symptoms related to multiple chronic conditions. So how do you manage those symptoms in a home setting? And with all the complexity of medications and newer medications coming out all the time. So it's a lot of clinical expertise that's required. And then certainly the sort of softer skill of having really putting the patient's goals and the family's goals in the forefront of your treatment planning, and having those what are sometimes somewhat uncomfortable, but really provocative and important conversations with patients and families about their own goals, both, during the illness course, but also thinking, for someone who may be moving into the sort of advanced illness and end of life, what do you want your life to look like, at this time and in the near future? The other thing that again draws, I think, a special workforce to this industry is that you're very rarely just working with the patient, because there's so many layers of support these patients need, and so there's often a family or a paid caregiver involved, that you really need to involve in all of the conversations and the treatment planning and the goals of care conversations. And sometimes there's family members who disagree about what should be happening with mom. And so then you're becoming almost like a little bit of a psychologist or a therapist, really trying to help soothe and manage the conflicts that can sometimes come up when, someone that you love is suffering. So there's those soft skills that are really important. And then just with so many different medications and testing required and the multiple chronic conditions that most of our patients care for. There's just a lot of care coordination. And, those care coordinators that I talked about that we have in our office, I mean, they are just, they're like the, air traffic controller of the whole team. They're really helping to be sort of the front line, talking with the family and patient, but then organizing all of the care and making sure that everyone understands if there are specialty appointments required, or there's a phlebotomist coming out to the home, or there are lab results that need to be reviewed. That care coordination is really, really important. Comfortable with technology. This is a tough one. It seems to me like this is just more and more important. And now that most of us are using a lot more telemedicine platforms, and we're doing things like remote patient monitoring. And sometimes we have several systems we have to use in order to be, texting patients in a HIPAA compliant way. There's just, application fatigue. But it is really important. It's just not something that we can ignore, that we need to have providers and care teams that are comfortable with technology, or be training them. Documentation and coding skills, not a favorite for most people that come into care providing and medicine. But this is also becoming really, really important in the world of value-based contracting, and we can talk more about this, but being able to really accurately capture the complexity of your patients helps you to get the revenue that you need to care for them. And if the payers don't understand everything you're doing and the complexity of the patient, they don't pay you as well, bottom line. And then also just being able to document so that other providers who are caring for the patient really understand what's happening and understand what the goals of the patients are. And then, the practice operations staff. So these are, people like the care coordinators, the billing staff, the leadership team, whoever is managing the revenue cycle. So for us, we also have marketing and communications. We actually have liaisons that are doing community engagement and really sort of fostering relationships in the community with assisted living facilities and senior living communities. Lots of people. And so there is some important competencies for the practice level staff and the leadership team. And so, at the very top, assessing and selecting the appropriate staffing model that really aligns with what your practice is attempting to do. And again, there's no right answer. And when Paul mentioned, you really have to look at what geographic region are you in? What are your payer sources? What does your revenue model look like? What kind of workforce is available in the region, and who can you collaborate with? If you don't have the budget to hire the full complement of multidisciplinary team members, who can you partner with home health agencies or areas for aging or other community-based organizations that can support the population? And then understanding, who is the target population that you really want to focus on. I mentioned that House Call Providers has been serving our community for almost 30 years, and the target population has really shifted over those years for a lot of different reasons. But, in 1995, the typical House Call Providers patient was a frail, elderly, homebound adult. And average age was, 85, multiple chronic conditions, Medicare eligible. The typical House Call Providers patient in our home-based primary care and palliative care program is younger. The average age is actually now around 79. They're not necessarily homebound. We take care of a lot of younger individuals now who have a complement of major sometimes advanced cancers, sometimes just multiple chronic conditions who have really failed in a brick and mortar setting and just need more support for a lot of different reasons. We take care of young disabled individuals who really are homebound due to physical disabilities. So anyway, that has really shifted over the years as the community and the healthcare system has understood the benefit of home-based medicine and has really reached out and wanted to refer patients to us. We are also expanding our geography. This is something that is really tricky to manage in a home-based practice because anytime you expand your geographic boundaries, you're adding, what we tend to call windshield time to your staff. And so it is for us, because we're covering, and I would imagine Paul's got similar stories, but we're covering 3 counties around a sort of a metro region. And 2 of those counties are sort of half suburban and half rural, and then 1 county is kind of in the urban center. The urban center is much denser, right? So those providers who have those territories aren't driving as much. And as you get out into the more rural communities, we have to be really careful. If we have a senior living community that is calling us saying, we want to partner with you and we have patients to refer you, but they're on a boundary or outside of our current service area, that's a strategic conversation for us, because we have to think about, like, are we going to have enough density, and are we going to have to shift everyone else's boundaries to be able to support that new geographic region? So we've got people who are really good at geomapping, and we have this software that we use. But even if you don't have the software, you have maps, and it's just a matter of, do you have enough staff? How much time? What's the drive time, etc. So it's a puzzle. So yeah, effective geographic scheduling, effective use of technology to enhance productivity, efficiency, and staff satisfaction. So, before the pandemic, we actually were not using telemedicine at all. And we might have been, we had it on our roadmap, and we were probably a little behind the times on that, but we just, we would call patients. There was a lot of telephone call. We didn't use any kind of telehealth application. And certainly that is one of the silver linings of the pandemic for us, is that it just forced us to really get current with all the technology. And now we use it more, and it does allow us to be more efficient. And it actually allows our primary care providers actually leave a slot at the end of every day for a telehealth urgent visit. And that allows them to kind of get an extra visit in the day once they get home and start their charting. And then based on that telehealth visit, if they really feel like the patient needs to be seen and they just can't, they can't do an effective visit with video, then they will go see them the next day. But at least it's a touch point, and they can do some triaging and education, and sometimes medication changes. And we didn't have that opportunity before. So that's fantastic. And I think is an important and growing part of our home-based practices. Establishing policies and procedures, another not a very favorite thing for most people, but those are important, particularly as practices grow. Payer contracts. That is probably about 60 to 70% of my job, is negotiating contracts with payers. And as Paul pointed out, the kind of care that we're providing, the kind of complex care we're providing, and the interdisciplinary team nature of this care is very difficult to, if not close to impossible, to be sustainable under a fee-for-service model. You can be the best coder in the world and have everyone educated on how to make sure you're maximizing revenue, but it still doesn't support the kind of robust team-based care that we would all really love to provide. And so the ability to get into all levels of alternative payment models, not just those that are fully risk-based. And when I say risk-based, meaning that you're taking risks for the total cost of care for a population and then earning shared savings if you're able to lower the total cost of care. That's what we started to be able to do in the Independence at Home demonstration in 2014 that we participated in, where we actually, Medicare paid us, more than half of the savings if we were able to lower the total cost of care for the Medicare beneficiaries that we cared for compared to a control group. But we also have, we have a lot of contracts right now we've been able to negotiate that don't have any shared savings components to them, but they pay us a set fee every month for the care. And it's, we refer to it as a primary care capitation payment or a per member per month payment. And so we still submit all the visit documentation that the payers usually want, but they just it's almost like an invoicing process. We take care of 50 of their patients and they pay us a certain amount per patient every month, which means that it starts to decrease the need for the touch points to always be with a billable provider or a primary care provider or a physician, nurse practitioner. It might be a social worker. It might be a nurse. It might be an outreach worker. It might be the clinical pharmacist. You get to actually tailor the services delivered and the team members that are visiting the patient based on what the patient's needs really dictate, versus having to send somebody who can actually bill the visit. So that is what we have moved to more and more. In fact, we don't have a single contract with a Medicare or Medicaid payer that doesn't at least have a combination of fee for service and this primary care capitation payment. And I think we're pretty rare. So I don't want to say this is something that everyone should be doing. It's market dependent. And the more you're able to demonstrate value through data to your payers, the easier it is to negotiate contracts. And because House Call Providers was early into the demonstration program with CMS back in 2014, we performed really well. And I've been able to use our performance over 7 years in that demo to actually go to local payers and say, look, if we can do this with Medicare, the federal government, we can also do this for you.
I want to turn it to the audience. What did Rebecca say that concerned you, that you would like to learn more about? What resonated with you? Anything at all?
I do have a question. I was part of the hiring committee for nurse practitioners at my former company. How do you retain staff, especially with the driving? I started off as a new grad in doing home visits, and I was burnt out by year one. I still go out to do visits, but how do you retain the staff, especially the amazing ones, long term? I mean, 5 years, 10 years, 15 years, going to these communities, going to the rural areas, driving, and as well as some of the communities that are not safe.
Yeah, I have some comments, and now I'll turn it over to Rebecca. What keeps me awake at night is staff retention. As you saw, I'm so lean. If I lose anyone, it's going to be a real mess in the office. So staff retention is a critical part of my thinking. Every day, in addition to seeing patients, I heard Mickey had a chuckle there. Yeah, we are struggling with hiring staff to help support our work in the South region with NM. So I would like to hear Mickey's comments as well. I don't have a simple answer, but there are a couple of things I would like to comment. One is I think you need to be competitive with your pay. So market analysis, I think it's important. Dana and I were talking about that the other day. The old days of just, and here's your pay and, take it or leave it kind of stuff. That no longer works. People want good salary plus flexibility, plus any additional benefits you may have. as part of your organizations, whether I think we talked about like a gym membership or even pet insurance as part of the benefit. So you have to be, I think, creative when it comes to the salary and the benefits and the flexibility side. The other is, I think, your practice, the spirit of your group. It's huge. If you don't come across in a very pleasant way, if your practice is like, it's kind of run down or whatever, fill in the blank, the providers may not be attracted to your group. Do your providers know your mission and your vision? And do you guys live it, or is it just lip service? Okay. And the third, and I'll just stop after this comment, I'm sure others can add, is to celebrate their accomplishments, celebrate what we've done as a team, okay? Take all, next week, the 25th, it's just, Rebecca, I don't know if you know this, is National APN Week, right? I think, right? So we got pizza coming. Okay, you get the idea. Great patient satisfaction, time to celebrate, okay? Because we get so many negative comments about, you guys didn't do this and that. That could wear on our providers. So take time to recognize the work that they're doing. And celebrate the accomplishments. And I'm sure Alicia next time can talk about, Rebecca talked about windshield time and then the whole idea of geographic creep. If we go to this town, that next town's only 5 minutes away, and then before you know it, you're driving 15 minutes out, right? But I won't get into that. Rebecca or Mickey, any comments?
I have a lot of comments, but it's great to get the audience. Yeah,
we recently switched our geography just a little bit, and you look at, okay, how can this person handle this, and how can she go all the way over there? And so we had to look at that service map strategically, and how many patients in each town, and then we did have to shift that territory just a little bit to accommodate that move to go to an area. But you get their buy-in as well, and it's not just the office making that decision for them. They're also part of that process. And I think if they have some input as to where they're going to be driving to, as a team, if we all do that together, it's presented a little more positively. I hope that helps.
I think retention is a great thing, and recognition, and putting together a total compensation package. That's what I kind of like to refer to. It's not, here's your annual salary. It's, here's your total compensation package. And that could be, we were laughing the other day. I was doing some interviews, and literally someone had shared that they had a job choice. And the decision for them was pet insurance. They were like neck and neck, and they were like, they had all these pets, and it was their thing. So I think looking at the total compensation as well as benefits. Don't forget that when you're approaching people, we like to think, yeah, we're going to make this amount of money, but how much is coming out of your paycheck for benefits? So I think those are important things, but I think it's even more important to wind back to the very beginning. What is your job description? What's the story? What's the underlying message in that job description? It will attract the people that you want to bring to your program. Are you using an interview guide to ask the right questions and trying to dig through some of those things? So, those that you interview, keep in mind, we like to think, oh, they're coming to us, we hold the cards. That's not the case anymore. That is a complete 180. So we have to make sure as we're talking and sourcing and recruiting and interviewing that we're keeping all of those things top of mind as we go along the life cycle. Because if you get the right person to begin with, they typically will stay longer, and then hopefully ease some of the attrition that does happen.
Any other comments from the floor before I give the mic to Rebecca? Julie has a comment.
At HCCI recently about the difference in orientation and onboarding. and that they're two different things. That orientation is your first day, your first week, but onboarding can last up to a year. And like Paul said, are you really seeing the values of the organization sort of demonstrated? I think those are the kinds of things that happen with onboarding, that you really experience what the culture is like and learn to be part of it and become kind of an ambassador of the organization. So we found that to be really important. I thought I would just mention it.
Thank you, Julie. Rebecca, you said you had a lot to say, and the floor is yours.
Yeah, this is the thing that keeps me up at night as well. And I think there are so many levers. I think probably for us, one of the most important has been the team. And again, this all goes back to, do you have the revenue to cover having a team? But the more you're taking, you're able to build a team-based model where one person doesn't shoulder all of the care on themselves. In my opinion, the more resilient the workforce is. And so we do so much to foster the team environment. In fact, we're actually one of our primary care teams is getting an award at the American Academy of Home Care Medicine meeting next month in Chicago. We try and really acknowledge, and every time we have a huddle with our primary care team, we start it with acknowledgments, and what that does is it's fostered this culture of people thanking their team members for the contributions they're making to the care of our patients. So a care coordinator will be thanking a social worker, and a physician will be thanking the clinical pharmacist. And we call it ongoing regard. And it's a practice that's part of almost every meeting now that we have when we bring teams together. I completely agree with whoever it was that was talking about involve your providers and your care teams in decisions, and as much as you can, listen to them. So we've also trained all of our leaders and a lot of our staff in lean process improvement methodologies. And what that's done is and we have an email box that people will email every week. Will email ideas to the leadership team about things that seem to be broken or inefficient processes or technology challenges or whatever. I mean, it's been all kinds of things. And then those are brought up during our huddles that we have every week. And we do a virtual huddle every Thursday morning. And there's a whole part of the agenda that's about, let's talk about the things that came in through the inbox. And then the bigger ones, we sometimes have to put together a committee to solve, and we'll involve part of the team in that. And again, it's not easy because, right, you have to do patient care. So how do you staff that? And we don't have time to go into all the ways that we've had to figure that out. But their ability to be part of the solution when there are challenges really helps with buy-in and engagement. The compensation package is incredibly important and becoming more important. I completely agree. We don't talk about what's the salary. We talk about what's the total compensation package, how many days of vacation, any benefit that you can add. We have a really good 401k program because we're part of a bigger health organization. That's not always possible, but and the flexibility. I mean, that's one thing that we try and do. And I think telehealth has really helped with this. Like what I said, we do a employee engagement survey every October. And for the first time in, I don't know, over 10 years, when during the pandemic, what we saw was that there's a question about work-life balance. And that one started to tick up, I think, just because people had a little bit more flexibility in terms of seeing patients remotely. And now we're probably back to doing like 80% in person and 20% virtually, but that made a huge difference. And I think it's related to flexibility. We also have a clinical mentor. So we have one provider on our primary care palliative care team who's a nurse practitioner. She's been providing care in our practice for, I don't know, 13 years. And she, 0.6 of her full FTE now is dedicated to mentoring staff that we, newer staff that we hire. And that's just been huge. I think really giving somebody support when they're orienting, but also onboarding for the first year has been really important. We do a lot of social events. So every month we do a get together on Friday in different various locations of the city. We're doing an all staff picnic this Friday where we're actually closing the office. We don't do this more than once a year, but we're closing the office. We're turning on the answering machine. And then we have just really lean staff taking urgent calls. And for 3 hours, we're meeting at a park and we're having playing games, and we have food, and so yeah, just fostering that culture of teamwork and belonging has been really important. And I'm going to stop there. I could go on, but I really appreciate whoever asked the question, because it's so important. This work is really, really hard, and I think the more that you can foster using very specific practices in your organization, the more you can foster a feeling of team and support and belonging, the more resilient the staff will be.
Thank you, Rebecca. For those of you who might be new to this or thinking about this is terribly demanding work, but it is so rewarding. I've been doing this forever now, and it was true 20 some odd years ago for me, and it is still true today. A couple other things I just want to add. Keep the thank you cards. Read them at the staff meeting, whatever, okay? Heartfelt thank you from people who are just disenfranchised. And without our services, just imagine where they would be. And I say this not in any way being proud or whatever. They have very little access, and they thank us for our care. Don't discount that. Have regular meetings. I completely agree with that. Whether it's a Zoom or our office is so small compared to Rebecca's. We have face-to-face meeting monthly, and we're meeting now with Mickey's team down south. It's a little further, so we're doing Zoom meetings when we can. Again, having that bonding time. And one last comment, two comments, and I'll stop, I promise. Have a platform for your team. We use Microsoft Teams, and we remotely have these huddles. We say, it's so-and-so's birthday, and then people can comment. Or when are the high-dose flu vaccines coming in, and people can comment. You get the idea, both clinical and also just personal accomplishments. And one last thing, and you don't have to subscribe to this. Actually, mine is, I need to dig this out again. Years ago, I used to have 3 buckets in the office. Okay, one is the thankful bucket. People can put in what are they thankful for their patients, for their job, whatever. That's the thankful bucket. The other one, I'm a Star Wars fan, so it's the Jedi skill bucket, all right? What Jedi skills do you have, or what did you learn this week, this month, on a particular, whatever. So there's a thankful, there's a Jedi bucket, and then there is the wish bucket. What do you wish things were different about your work, and so on. You can design your own. Again, it's about involvement, getting buy-in, that you're just not a number, that I'm just using you to go through the grind of the treadmill of fee-for-service, that they are making a difference, and that we value their care, and so forth. Rebecca, as we're looking at this a better way to take care of these sick and complex patients in a more holistic way, why do you think this is important moving forward, especially as the landscape is now changing from fee-for-service you mentioned value-based care, whether it is shared savings, whether it's a or per member per month model. Why is Northwestern now looking to me, having me involved in a lot of their decision making and so on? Can you give us maybe a historical perspective, having been in this for a long time, and if you can give us maybe your projections of the future?
I don't even know where to start. I think that we are in a really unique time right now that has arisen as a result of a number of large demographic and geopolitical events. I think that the healthcare system is pretty broken. Most of us know that. The cost of care has just skyrocketed, and healthcare systems were already struggling before the pandemic, and now, major hospital systems in our region, and I know this is common across other places, are just really struggling, closing their doors, merging with other bigger companies because costs are just so high. And then the pandemic hits, and all of a sudden, those of us who have been providing home-based care for decades become visible to the rest of the healthcare system because no one wants to go into the clinic or into the hospital. In fact, people are being urged not to. And so payers and large health systems all of a sudden start to recognize the value of home-based medicine in a way that we had been trying to get them to understand it for years. And it, in the early, 1930s, 40s, 50s, it was much more common than it was in the 80s and 90s. And so it's like this pendulum has swung, but a global pandemic like this really opened people's eyes. And all of a sudden, instead of the sort of, I would say, the clinical leaders and care providers understanding the value of this kind of care, all of a sudden the people who purchase healthcare recognize the value of it. And that's one of the reasons why contracting for our house call providers has become easier, is because all of a sudden payers are literally much more interested in it, want to learn more about it, want to talk about what the benefits are, not, from a quality of care perspective and from a cost perspective. So I absolutely believe that the future holds a lot more interest at the payer side of things for home-based medicine. I think that, the silver tsunami, whatever you want to call it, the demographics of our population are changing, and consumer demand is really shifting as well. People want care in their home. They want personalized, customized care. They don't want a big bureaucratic system anymore. And so, I think the advent of telehealth has pushed this. I think the pandemic has amplified this consumer trend that was already happening. And ultimately, the payers of healthcare have to pay attention to what the consumers want as well. So I just think all of these shifts are happening, and they got amplified by the pandemic, which just really forced people to take a look at our healthcare system and where the gaps were. I'm just seeing a lot more openness and a lot more demand. That's the thing. Like the thing that is keeping us from growing faster is our ability to really hire and train workforce. So I think everything that HCCI is doing and all of the sort of work that practices that even the Academy of Home Care Medicine is doing to try and create policies that really support education for workforce, all of that needs to just continue to happen, because we need more in the pipeline, more people who really are trained to do this work, who understand the value of it and how rewarding it can be. Yeah. So I don't know if I answered your question. I hope
That
I
was
did.
awesome. Thanks so much. Let's move on. We have a few more slides. Rebecca, we were hoping that you and Paul could share, how do you build this case? How, if you're in a system and you want to start home-based primary care or bring the two models of care together, where do you start? So I'll turn it over to you.
Yeah, I mean, I think you have to start with whoever's going to pay for the care. And so we happen to be in a region that is heavily Medicare Advantage. So, and that's different across the country. I know Chicago is different than Portland, but there are a lot of Medicare Advantage payers in our region. And I think that they are very interested in keeping their market share, which means they need to have satisfied patients. They need revenue from the government, and they get revenue to then pay providers if their quality scores are high. And they want to lower the total cost of care. And so those three things are what sort of payers pay attention to, and then patient and consumer satisfaction. So I guess, for me, I have a payer background. So that's part of my expertise, but in other words, I used to work for a payer on a clinical side of things. I think you develop the relationship with a payer, and then you have a dialogue, and you find out, what are they looking to solve? What keeps them up at night? What target really, we care for the most expensive patients. I mean, home-based medicine is designed to care for the most expensive and the most complex patients. And so you got to start with having the conversation with them about, what you think you could do to care better for those patients that are costing the payer a lot of money and that are difficult to, to get their quality gaps in care, et cetera, closed. And there's just a unique value proposition for home-based medicine because, we get to see the whole patient in their environment. And there's a lot of data out there that suggests that by and large, this type of care lowers total cost of care. So I guess that is where I would start. And if you don't have the data, you have to be convincing and be willing to, start a pilot and have the payer watch the total cost of care for those patients. And, because eventually they're going to want to see the data. Paul, what do you think?
Lots to say, running a little short on time. So building a case. So you heard Rebecca. Let me back up. We need money to run a practice, right? Whether you're funded by a payer, or for me, I'm funded by a health system, right? So building a case. You heard Rebecca about lowering the cost of care and so on, and doing great work. We are doing the same, but my approach has to be a little bit different. I don't deal directly with payers. I work for Northwestern. Okay, so my approach, depending on your practice, where you are, you may take a little sprinkle of what Rebecca's saying, and also maybe hear a little bit of what I would suggest. I try to be involved in committees and whatnot with Northwestern to find out what their pain points are. What are they struggling with? What headwinds are they facing? And then I'm going to try to align my work and show data. Yes, we haven't talked about data. That's another talk for another time. It's important for you to collect data to show what you're doing is valuable to the health system to overcome their pain points. Julie and I had a conversation a couple of weeks ago. If you look at the Northwestern, the health system, and hospitals across the nation, the operating margin is extremely small. What can I do to help them with their operating margins? Can I keep people out of the hospital? Can I keep them out of the emergency room? Can the hospital be, can I facilitate a discharge of these patients home to the hospital? So more beds open up, more patients, or maybe the right kind of patients. I know that sounds bad. The right kind of patients would be in the hospital. Can I help the hospital with their pain points, whether it's access, discharge, finding the right kind of patients, and so on. And the other is with their quality measures, their star ratings. That's important to them, right? Rebecca talked about that as well. What can I do to help them with their star ratings, so that when they negotiate with contract with payers and whatnot, when people look online, they'll say, that's the entity I want to work with. So I'll just end with that. Whether you're working with a payer or you're working with the system, find out the pain points for them and how you can align and help them be a better organization. Those are my comments.
So after you've built the case for the care, then it's like, how do you start providing the services? And these are just some of the things that you need to keep in mind that are going to be critical as you start to build this practice. How are you going to handle intake and registration for new patients and processing referrals? Often when you take a new patient on, there's a lot of medical records that, providers are going to need access to. And so, what information are you asking the patient and caregiver to provide up front? What kind of consent process? Can it be done electronically? Does it need to be mailed in? All of those sorts of things. You've heard both Paul and I talk about the importance of scheduling and route planning. There are a lot of platforms available now that are GIS enabled. So, if you have the budget to be able to do that, otherwise, often it's a spreadsheet or a map. But, I would highly encourage looking into some of the GIS scheduling platforms. How are your teams going to communicate? Do you have a secure way of are they using an electronic medical record to communicate between them? We happen to have a HIPAA compliant text platform that we use that's outside of the EHR. And then they also use the EHR inbox messaging, and then certainly care plans and such within the EHR. Thinking about what kind of standards of care or protocols you want to have or need to have in place given your patient population. How are you going to handle 24/7 access? I think it's incredibly important, and usually it's a regulatory requirement for most contracts to have 24/7 availability. That doesn't mean, just like Paul, we don't send providers out in the middle of the night. We do have a nurse that's available to make visits on the weekend, but otherwise it's consultation and telehealth and phone. But you have to have, so we have a whole call schedule that we have to manage for our 13 plus providers. And then billing and coding is going to be important. So what's your revenue cycle team look like, and what kind of expertise do you have? The right expertise on that billing team? How are you going to train your providers? One of the things that I actually think enhances staff and provider resilience is the ability to continually learn. So not only orientation and training for new providers, but how are you offering training opportunities and CMEs for your provider teams and your clinical teams? What kind of EHR are you going to use? And is it flexible enough for a home-based clinical practice? And then how are you going to manage vaccine storage, medical supply storage, any kind of equipment? What kind of vendor agreements do you need with, we don't have our own phlebotomists, so we actually partner with a mobile phlebotomy company. Some practices have hired their own phlebotomist. And how are you reimbursing your providers for travel? So do you have a good system for collecting their mileage and reimbursing for that? Those are some of the things that you'll need to be thinking about as you open the practice or grow the practice.
Oh, sorry, just a quick comment. Getting back to, I forgot to answer one of Alicia's question, and that's about maybe unsafe areas. So getting back to what you were saying, having office procedure, where did we go? So one of the procedure and operations may be your safety of your staff. What's your safety protocol for staff in the field? Do you have a tracking app? Some people like it, other people don't. Do you have a safety procedure, like you call into the office, the back line, and says, Dr. White, I need Dr. White, that's your secret code that I'm in trouble. Do you need to do visits in the daytime, less so in the evening, especially here in Chicago when it gets dark at 3 in the afternoon in the wintertime? Do you have to look at your scheduling differently depending on the season and neighborhood? So safety protocol, neighborhood consideration, do you need to send people out in pairs? That might not be the most financially it might not be financially whatever, it costs more money to do that. But as we're talking about having happy staff and retention, if that is what's keeping me up at night, then the money aspect will have to be considered at another time. Oh, please.
Yep, we'll give you a mic.
Mickey.
We have had to have on a few occasions, have the security from the hospital go with the nurse practitioner. I know I worked for a company prior to coming to this hospital, and they had an external company that was a lot of off-duty police officers that they had a contract with that would go out with the employee. We've always told our staff, your safety comes first. We do go through once a year at least safety concerns when you're in a home, and have your back, make sure that you're not backed into a corner, all the other different approaches that they can do to protect themselves. But if they are at all uncomfortable going to a certain area, they do have that right to let me know, and then we would get security lined up and they would go with them, and it does make them feel more comfortable.
And I just want to make a plug that everything on this slide is really a teaser for what we're doing in December. We're going to be talking about operations, and not just what to do, but to how to design these processes in the most efficient way possible. So you'll be hearing more about that in December. So Rebecca, why don't we kind of make this the last content slide, if that's okay?
Yeah, and as I look at this, I think we've talked about all of this, to be honest. I think the one thing that we didn't touch on very much was how do you generate demand? And whether you use the word demand or market or whatever. I think that in addition to everything that I've said about payers, for us, and again, we don't have any problem with this anymore, but initially, in order to help generate referrals, it was a process of relationship building with referral sources. And for us, that has been primarily other providers in the community, FQHCs, other specialty providers, but even more so, senior living community owner-operators, assisted living and memory care owner-operators, adult foster home owner-operators, hospital discharge planners, Medicare brokers. So there's a whole, we have an actual marketing team that are liaisons, they're really community engagement specialists, and they're developing those relationships ongoing. But those are the types of organizations in the community that are going to really benefit from this type of service, and those relationships are super important to establish early on. The only thing that I didn't talk about was that we also operate a hospice. It's in the slides. I know there's at least one, maybe two hospices in the audience. a lot of we kind of did this a little bit backwards from a lot of the trend right now. We're seeing a lot of home-based hospices start to diversify and start providing palliative care, and now even looking at diversifying and providing home-based primary care, which makes a lot of sense. So you actually provide that full continuum of home-based services. We started at the other end, and within, several years recognized 25% mortality rate. Gosh, it sure would be nice to provide end-of-life care for these patients we've been caring for many, many years. And so in 2011, Haskell Providers opened a hospice, initially just for our own primary care patients. And then word got out, and because of our great reputation, other primary care and specialty providers wanted to refer to our hospice. So we actually opened it to external referrals. And so now we have about 50-50. And so with that, and then in 2017, we opened a community-based palliative care program that is actually separate from our home-based primary / palliative program. And that program is focused specifically on Medicaid and dually eligible patients. So it's a robust team-based model that wraps around a brick and mortar, typically a brick and mortar primary care provider or cardiologist, oncologist. We work a lot with oncology providers. So there's been a lot of growth and expansion over the last decade or so for household providers.
Any comments, questions? Yes.
You already know.
I had a question about payment models. I'm just curious to know, well, I guess two hopefully small questions. The first, are you aware of any home-based primary care practices that are successfully using a direct primary care payment model? And then the second question is, have you had experience with insured patients who find the cost of the home-based services prohibitively expensive if they have high copays for the visits, like for TCM or CCM, things like that?
Yeah, so I'll answer the second question first. No, we've been doing this for a long time, and for us, and again, being a health system, we are, quote, non-for-profit, right? And we take care of refugees, okay, people who can't pay. So at the end of the day, we do take care of patients whether they're able to pay or not. So it has not been a barrier for us. Your first question about, say, patient care, patient first, or other APM models. Northwestern is currently not involved in any APM model, sadly. But there are other practices that if you're interested, we can get you connected. You can certainly have Rebecca give her thoughts about value-based care, different APM models. And there's even a new one that's being piloted, I think nationally, the GUIDE. You can Google GUIDE for dementia care. Again, that's an opportunity for you to gain additional dollars to help take care of patients who are sick and complex with dementia in this particular case. Rebecca, any comments?
Yeah, there are a lot of home-based primary care practices who are participating in alternative payment models such as Primary Care First. We are participating as an ACO REACH, a REACH ACO, which allows us to earn shared savings like we did when we were enrolled in Independence at Home. And there's new models coming out all the time. We put an LOI in to participate in the GUIDE model, the dementia care model that Paul just mentioned. So a lot of these models are actually being designed specifically for this very complex population that we're talking about. Really good opportunities.
This is the future. Care at home is the future for multiple reasons. Payers, aging population. You can find out a lot of the resources or talking points, if you will, on our ACCI website. How do you talk about home-based primary care to people, anybody who would like to listen? This is the future. Our patients are sick and complex. The wraparound care is really, really important to take care of these patients. Mickey and I were talking about the growth, the demand for palliative care. The home-based palliative care program has been around since 2017, and it is growing because the demand from oncology, from cardiology. I mean, it's the same. Is exactly what Rebecca is talking about. So the pressure from payers to control costs, improve quality, the demand, the aging population. This is, as Dr. Cornwell said, this is the perfect storm of the changes that Rebecca was talking about. That this is what does she say? This is a very unique. It is really a unique time. So for those of you considering extension of a hospice program or doing home-based primary care, this is really a unique time in medicine.